clinic opportunities. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to questions posed after the webinar via email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Martie Ross and Traci Waugh.
Thank you, Trevor. Greetings from Kansas City, the home of your back-to-back Super Bowl champions. I'm Martie Ross, joined today by Traci Waugh, who is in our up in Kalispell, Montana. And when you think rural, you think Kansas and Montana. In fact, going back to the 90s, I'm dating myself, but back to the 90s with the original Each Peach demonstration project. That eventually became the Critical Access Program. That was Kansas and Montana. Now, Bob Dole and Max Baucus created that program for us. But we're excited to talk about the Rural Health Clinic program today. In fact, it predates Critical Access Hospitals, Soul Community Hospitals, rural referral centers. This program goes back to the late 1970s. And it was intended, sort of this first special payment model within the Medicare program, intended to fill that gap between high cost of providing services and lower volume of services. And that is the challenge in rural healthcare, is that we have the same high fixed costs for delivering care, but lower volumes. And so it's more difficult to make the math work. And so the Rural Health Clinic program was intended to provide that additional reimbursement to rural providers. There are approximately 4,500 rural health clinics throughout the United States. That number is growing, and we'll talk about the reasons that more clinics are pursuing the Rural Health Clinic program today. Why do you want to be an RHC? The main dominant reason is that you're going to receive enhanced traditional Medicare and Medicaid reimbursement for RHC services. RHC services, should have quotes around it, it's a defined term. We're going to spend a lot of time talking about that term. State Medicaid programs generally follow the traditional Medicare payment methodology. So we're going to focus on those traditional Medicare payment methodologies today, but there is variation. As we always say, there's not one Medicaid program, there are 56 Medicaid programs. And those in states where there are RHCs will trend to treat, there'll be a few clicks, a few changes here and there that will vary reimbursement. But for other payers, including Medicare Advantage, it is a matter of negotiated rates between the payer and the RHC. And note that for Medicare Advantage in particular, there is no wraparound payment for RHCs. For an FQHC, there is additional reimbursement available to FQHCs to make up the difference between traditional Medicare and Medicare Advantage rates, but there is no similar wraparound payment in the RHC program. So let's delve into that. Let's talk about this difference between RHCs and FQHCs, because this is a matter of confusion, in large part because if you go to the section in the Code of Federal Regulations that talks about the conditions of coverage to be part of the Rural Health Clinic program, it is also the same provision that addresses federally qualified health centers. And again, the FQHC program is, the OG program because it goes back to 1965 when you created the Medicare program. And same thing, it was intended to provide additional special reimbursement for clinics that serve lower income populations and provide access to care to those individuals. So the two are aligned. They're both a special payment methodology to help providers that serve a particular population, but that's where the similarities end. And there are a lot of times we'll hear people say, well, doesn't this apply to an RHC? I'm like, no, that's an FQHC role. So let's distinguish between the two. If you are a federally qualified health center, one of your core requirements is to have a sliding fee schedule, which means that you provide care regardless of a beneficiary's ability to pay or any person's ability to pay. That is not true for the RHC program. So you do not have to have a sliding fee schedule as a condition of being an RHC. In the FQHC world, there are specific rules regarding the governing body, and that in fact, FQHCs are limited to not-for-profit organizations or public entities. And the governing board has to consist of at least 51% of patient or patient representatives. Again, not true on the RHC side. Rural health clinics can be, and often are, for-profit organizations, and no special rules regarding their governance. The 340B drug pricing program is one of the significant benefits to the FQHCs that is not available to rural health clinics. The question we receive frequently is, how do we gain access to the 340B drug pricing program? What if we create an RHC? That's not going to get you there. They do not participate in the program. Now, if you are a provider-based RHC to a critical access hospital, the critical access hospital enjoys 340B program participation. And through that relationship, as a provider, provider-based department of the hospital, RHCs can access the 340B program, but an independent RHC does not have access to 340B. FQHCs enjoy Federal Tort Claims Act protection, which obviously significantly lowers the malpractice costs for those clinics. That is not available to rural health clinics. And finally, our federally qualified health centers have a dedicated grant funding through the Community Health Center program run by HRSA. Again, there is no additional payment to an RHC beyond that enhanced reimbursement that they receive through the Medicare and Medicaid program. So there's our groundwork of why you want to be an RHC and why you'd really sometimes like to be an FQHC, but certainly a different set of issues associated there. So let's talk about, how do you become an RHC? You have to be located in a rural area that has been designated as a shortage or underserved area by the Health Resources Service Administration, or HRSA, within the last 4 years. And there are tools available on HRSA's website that you can look at your location and determine your eligibility. You see at the bottom of the page the link to those resources. The good news is that there's no decertification process. So if you are designated as an RHC because you're eligible by location, if that is no longer a rural location, and that does shift based on census data, or if it's no longer a shortage area or an underserved area, then you're going to maintain your RHC certification. That's the reliability built into the program. By comparison, again, FQHCs have to serve a population that is in a medically underserved area or a medically underserved population. Those rules do not apply to RHCs. It's truly just where you're located is going to determine whether you're eligible for the program. The clinic then must satisfy the Medicare conditions of certification. That is accomplished through a state survey agency doing an on-site, both a desk-based and an on-site survey to determine compliance with those requirements. The most intensive requirements, let's highlight those, include staffing. That to be an RHC, you must employ at least one nurse practitioner or physician assistant. The key word there is employ, not an independent contractor relationship. That must be a direct employee of the RHC. You also must have a non-physician practitioner, specifically a nurse practitioner, a physician assistant, or a certified nurse midwife working on site to see patients at least 50% of the time the clinic is open to provide services. And again, these don't have to be employees. This can be through an independent contractor relationship. But if you're open 40 hours a week to provide services at RHC, then you're going to have a non-physician practitioner available to provide services 20 of those hours. And again, not just physically present, but available to provide services at least 50% of the time. Also, to qualify as an RHC, you must perform within the facility specified CLIA-waived lab tests. So very basic lab tests. We'll talk about the fact that those lab tests are actually not RHC services, but that's one of those intricacies of the program we'll talk about, but you do have to have the capacity to perform those at the clinic site. You must be capable of providing, quote, first response services to common life-threatening injuries or acute illnesses. So it's certainly not emergency level care, not provided through the RHC, but typically you have to have the capacity of an urgent care clinic and be able to respond to those conditions that would present on site. It's very mishy-mashy as you read through both the regulations and then the interpretive guidelines as to this first response requirement, but generally having that capacity to respond. Doesn't require additional hours that you're open, available to provide those services, but when you are open, that you have those capabilities. And finally, you have to provide primary care services, 51% of total practitioner hours. And primary care services, generally defined as family practice, internal medicine, OB, and pediatrics. So if you look at the total number of hours being provided in the clinic, it should be performed by physicians or non-physician practitioners that would qualify as providing primary care services. That, again, the common misconception, you can provide specialist services through an RHC. Either the common arrangement is leasing space to the specialist that comes to the clinic for a certain number of hours, and that specialist just bills those services themselves on the Medicare physician fee schedule. Or we do have some arrangements where you'll have a specialist who divides time across multiple rural health clinics and does a reassignment, and in fact those are billed as RHC services, and appropriately so. Finally, each permanent location of the RHC must be independently certified. So each location is going to have its own CCN number. That's, again, different than FQHCs, because FQHCs can have multiple sites that are billing under the FQHC CCN 10. But for RHCs, a hospital, for example, may have 3, 4, 5 provider-based RHCs. Those are each going to have separate CCNs and have to each demonstrate compliance with the certification requirements.
And Martie, just to add, so, you covered, some of the qualifications, but there's additional things to be aware of if you're preparing for that survey that you need to be aware of. There's specific signage requirements and listing of hours. And so just know that there's another checklist to be conscious of as you get prepared for becoming an RHC, or you may be resurveyed.
Exactly. Then the resurvey, that's very important, Tracy. The survey sort of shut down during COVID because of resources, but we're getting to see more state survey on site coming up and around. Unfortunately, we didn't have a 2-hour webinar today, so we just wanted to hit the highlights of those requirements. Absolutely. So let's talk about RHC, traditional Medicare reimbursement. We're going to start and focus on what are referred to as RHC services. And you'll see there are 5 categories of RHC services. And then near the end, hopefully before the clock strikes the top of the hour, we'll talk about RHC billing for non-RHC services. Yes, that sounds counterintuitive, but rural health clinics can bill for what are non-RHC services. So starting down the road with the all-inclusive visit rate. All-inclusive rate, exactly. And this is where we get into the distinction between a provider-based RHC and an independent RHC, because the air is different for the two. If you are a provider-based RHC that is associated with a hospital that has fewer than 50 beds, and you were certified as an RHC prior to 12/29/2020, or the date that the Consolidated Appropriations Act 2021 was signed into law. These are referred to as grandfathered RHCs. Your AIR is based on a cost-based reimbursement model. And those AIRs can be significant. They can be in the 200+ range for their rates. And they will continue to receive that cost-based reimbursement through the adjusted AIR. Note, and this is important, if you are a grandfathered RHC, you are permitted to change your permanent location and maintain your grandfathered status, but you cannot expand that grandfathered status to additional permanent locations. Remember, each location has to have its own CCN, and that grandfathered status travels with the CCN. Nor can a provider-based organization sell its RHC to an independent physician practice. That's not permitted because the provider-based status has to remain with the hospital. So there's not a way around for capturing that higher air that a provider-based grandfathered provider-based RHC enjoys. So they're locked in. We know who those clinics are, and again, they can relocate, but they cannot expand to additional facilities, nor can they sell to a third party. Everybody else, so that's your non-grandfathered provider-based RHCs, as well as your independent RHCs, receive a standardized national AIR. The AIR does not adjust by geography. So this is not like the physician fee schedule where you always are looking at what geography am I in, because it adjusts based primarily on workforce costs. Nope, this AIR is the same across the United States. Now, if we go back to before the passage of the Consolidated Appropriations Act 2021, specifically before April 1 of 2021, that rate was $87.52. And you know what? The math didn't work. That's why we didn't have very many independent RHCs. It was better for most physician practices, even if located in a rural area, to continue to bill services on the physician fee schedule. There just wasn't enough juice to go through the additional requirements of being an RHC. But then comes the Consolidated Appropriations Act. It shut down cost-based reimbursement for any new provider-based RHCs, but it also started ramping up the national standardized AIR. So where we said today, in 2024, that rate is now $139. And that will continue to increase on an annual basis until 2028, when we'll reach $190 as the AIR. And then going forward, it will be adjusted for inflation, similar to the PPS models that we have today. So that's pretty significant shift in the RHC program. And now creating this opportunity for independent physician practices that are located in rural areas to convert to RHC. As we've been doing math for different practices that are considering this, it's obviously going to depend on your Medicare and Medicaid mix, but in most cases, it is a compelling financial case to transition to RHCs. We're also seeing a number of health systems, urban-based health systems that have clinics in outreach areas and rural areas. And again, they never saw the advantage of transitioning to an RHC because they may have been provider-based, but they had more than 50 beds. But now, again, that increase in AIR creates a really significant new opportunity for practitioners in rural areas to receive this additional reimbursement.
So let's talk about what defines an RHC, a rural health clinic visit. So what's very important is what you see right there, face-to-face. There needs to be a face-to-face visit with an RHC practitioner. This can be the physician, the nurse practitioner, the certified nurse midwife, all those providers listed there on the slide. There are limited circumstances in which a visiting nurse service is included, which we can talk about later. And the location, it's anywhere but the hospital inpatient outpatient setting. Being conscious of if your RHC provider, if you're provider-based specifically, and your provider goes over to the hospital and does services, that's not under the RHC bill, that would fall under the hospital. There's also a link on the bottom here that talks about a non-exclusive list of qualifying visits. So it's a list of HCPCS codes that are qualified for RHC visits, the E&M, the procedures. Again, it's important to realize there's some of those minor procedures that can be performed in your RHC, that same provider is going over to the hospital to perform them. That's separate. That doesn't get included within your RHC AIR. That's on the hospital side, again, for provider-based. And that list, there's a link there, and that was last updated in 2016. So, you know, a few years have passed since that list has been included with lots of changes going on.
Yeah. And no real additional guidance coming out of CMS on what type of visit's going to be a qualifying visit. And the only other thing, Traci, just to highlight, and we'll talk more about this when we get to telehealth, there are different rules for behavioral health services. They can be performed via telehealth as opposed to being face-to-face, but let's talk about that when we get to telehealth, right?
Right. On the next slide, we talk about preventative services. So this is important to know that the list below of all these preventative services are part of the all-inclusive rate. Except, and then if you have an initial preventative physical exam, all preventative services are furnished on the same day or are one billable service. But if you have an IPPE with another service, that could be 2 visits on that bill. That's the one exception on there. And I know I was initially confused when I said the lung cancer screening with low dose CT scan. That's really the evaluation to see if you qualify for getting that low dose CT in the hospital setting. And again, as noted, there's no copay.
Right. This is the good old, there's provisions of the ACA that says in Medicare, you don't pay a copay if it's a preventative services that has been approved by the U.S. Preventative Services Task Force, is designated as a level A or level B preventative service. So that's what this list is generated from. It isn't just, hey, let's think of some preventative services. These are the actual approved preventative services.
Yep. And then services that do not qualify as an RHC visit, these are the ones that generally might be just being done by the nurse if there's just a refill, the review of the lab results that occurred a few days before, just taking a blood pressure. Patient may have went to the ER, had some stitches, and then has to have those removed. That's not going to count as a face-to-face visit that you can charge. There are, if physical therapy, occupational therapy, sleep therapy services are those, if they're provided by a non-RHC practitioner, those don't qualify as an RHC visit. And I think, we're up to you now, Marty.
Okay, so we know what an RHC visit is now. How do we reimburse it?
I know I left this one for Marty to cover. We all struggle with it.
Show me the money, Traci. Here we go.
Yeah.
So Medicare is going to pay an RHC 80% of the applicable air for nearly all goods and services that are furnished as part of an RHC visit. So that's why it's an all-inclusive rate, because you have the visit, which is a point in time and place. Everything that you provide at that point in time and place is going to be reimbursed by Medicare under the air. Okay, so you're going to get 80% of either your cost-based reimbursed air or that national standardized air. However, qualifying preventative care services are paid at 100% of air if it's the only service provided that day. So if a person comes in for an you're right, it's hard to say, Traci, IPPE, and that's the only service you provide that day, then you're going to be paid your full air rate. It's redundant, air rate is redundant, I apologize, but you're gonna get your full air, and you're not gonna have a copay to bill to the beneficiary. If you provide any other service that day though, then we get into the rolling it up to the CG line, we'll talk about in a second, for that preventative service. Of course, forever and ever, at least for long after I retire, and at this rate, Traci, probably long after you retire, it's still subject to the 2% sequestration. So you don't get 80%, it's actually 80% minus the 2% sequestration. The beneficiary co-insurance in an RHC is 20% of RHC charges, not the air. And there is confusion around this. And in fact, there are some MACs that will say on their websites that RHC copays are 20% of air, but in fact, very clear in the regulations that you calculate the copay based on 20% of charges. And you'll see in a few minutes how impactful that can be. And remember also that the Part B deductible does apply to RHC services. So you would look for, if it's early in the year, you look for first dollar payment coming from the beneficiary or their supplemental plan, if appropriate. What is all inclusive? And we have a very complex set of rules here. We'll try and simplify them as best we can. And again, as I said, it's a time and location issue. but encounters with one or more practitioners or multiple encounters with the same practitioner on the same day at a single location equal a single visit, with 3 exceptions. So everything you do for the patient that day, whether it's one provider who sees them or 2 or 3 or 4, everything's going to roll into the air with 3 exceptions. Number 1, that patient suffers an injury or illness that occurs after the initial visit that requires additional diagnostic or treatment services that same day. So they're treated in the RHC, they go outside, they get hit by a bus, well, minor injury by the bus, okay? And they go back into the RHC to be treated for that injury. That's going to be 2 separate visits. So 2 separate airs paid. Second is you have a medical visit and a behavioral health visit on the same day. So you have the services that distinctly qualify as an E&M service or a procedure that's performed, and you have a distinct service that meets the requirements to bill for a behavioral health service. Again, that's going to be considered 2 visits. Third, a beneficiary that has an IPPE and a separate medical or behavioral health visit on the same day, and it's just the IPPE, it's the only preventative service this applies to. In that case, that would be 2 visits and 2 airs will be paid. Also then included in that all-inclusive rate are going to be those services and supplies furnished incident to the RHC practitioner services. That's going to include, interestingly, services that are furnished within a medically reasonable time frame before or after the RHC visit. So for example, if you have a series of injections you're going to be doing before or after an RHC visit, those are going to all, again, fall into the all-inclusive reimbursement. When you bill for those, the date of service is always going to be the date of the RHC visit. Don't do a to from, or the system literally explodes if you do that. Also included in the RHC visit is the professional component of any diagnostic testing that's performed in the RHC facility. Okay, so if you run an x-ray and the doc interprets the x-ray, that professional component is going to be part of that all-inclusive visit. The technical component is a non-RHC service. We'll talk about that in a minute. Then minor surgical procedures that are performed at the RHC facility are also going to roll in. If its service is performed at the RHC, then the global billing requirements that would associate with that procedure do not apply. So any follow-on visits would be separate visits, separately reimbursable, unlike if it's performed in the hospital, where the rules would apply. So even if you have an RHC practitioner who performs a procedure at an ASC or a hospital, in that case, the rules, the global billing rules would apply. So if that patient comes on for a follow-up visit to the RHC, and now we got the global billing, right? Because the patient, that practitioner was reimbursed at a global rate for the service provided in the hospital or in the ASC. So it would be inappropriate then for the RHC to drop a claim for that follow-up visit. That would be inappropriate, unless of course some other service was provided at that visit that would be separate and apart, different from the surgical follow-up care.
And Marty, is that regardless of who performs the service at the ASC, if a different provider sees them at the RHC?
Right. Correct. Correct. Unless it's unrelated. I mean, remember the global surgical period it attaches to the MPI that performed the service. And so if it's another RHC practitioner performed the service and they're seen by a different RHC practitioner, that doesn't work, right? In the RHC. But if it's a non-RHC practitioner provides that service and then the patient shows up, then that could be an RHC service. That's just how the global billing rules work. Okay, so let's get into some fun on claim submission. So buckle down. We're going to go into a lot of detail here and it may get very confusing. When you submit a claim for an RHC visit, you're going to list on the claim by line item detail codes for all the services that are furnished during that visit. You will append the CG modifier to that code that identifies the primary reason for the visit. Now, typically that's going to be the E&M code. And then, so the E&M code is going to carry that CG modifier. And then any other service that's performed as part of that RHC visit is going to be separately listed by the CPT code. There are instances, there's instances where you could have two CG modifiers appearing if there are two separately payable services furnished on the same day. And in particular, this is going to occur when you have a behavioral health visit and a medical visit occurring on the same day. Remember, that means two errors. So that means we're going to have two lines on our claim for that day that are going to have the CG modifier attached to them. You then, and this is where it begins becoming very confusing. You will list on the claim your charge for every service, but you're going to roll them up to the CG modifier line, except those preventative services that Traci talked about. Because remember, there's no copay associated with preventive services. So we can't roll up the charge for a preventive service into that top CG modifier line. That's because the CG modifier line is how we calculate coinsurance. So it's all your charges for the services rolled in to that CG modifier line, except preventative services. That's going to be the number where we're going to calculate our beneficiary coinsurance off of. You will use the CG modifier for behavioral health services. If you had two separate E&M services provided on the same day, so remember the patient walks out and gets hit by a bus, in that case, the second E&M code is going to carry a 25 modifier on it. And that again will also indicate to the MAC that's a separately payable service. Then you're going to use the 59 modifier, of course, right? If you did an IPPE on the same day as a medical visit or behavioral health visit, because 59 modifier applies to non-E&M services, and IPPE is a non-E&M service, so you would use the 59 modifier in that instance. This was a question, and I appreciate everyone who, when they registered for this webinar, included questions, because that's very helpful for us to make sure we're hitting all the relevant content. This was one of the questions that folks posed, is when do you use the 25 modifier, when do you use the 59 modifier? Again, you're only going to use CG modifier twice, or the 25 modifier, or the 59 modifier on the line that is in fact separately payable as its own error. You do not list the 25 modifier on all those services that were provided as part of one RHC visit. So let's get into this table and try and walk you through how a charge would work. So we're going to talk about one day. I chose January 3rd, 2024, and this may be one of the most complicated RHC bills you could imagine, but it's going to illustrate how these different rules work together. So in our case, a patient's going to show up for an office, a traditional established patient office visit, the good old CPT 99213. We know they're also going to be visiting with a behavioral health specialist, so we're going to have some psychotherapy that's going to be performed that day. And then in our example, patient goes home after having been at the RHC, falls ill, and the RHC practitioner actually goes to the patient's home to see the patient. So this is an illness that was not part of the original visit. And so we have a home visit that occurs after that RHC visit. I want you to assume, for purposes of our example, that the RHC's charge for that 99213 is $200. Okay. So let's see how we roll these charges up. So again, you'll see that line 1. You'll see the office visit, which is the primary reason for the visit. It has the CG modifier attached to it. Now remember, the charge, the RHC's charge for that service is $200, but I have listed here $320. How do I get to that? because I have these additional services that are listed on the claim that were part of that RHC visit, including the professional component of an EKG, venipuncture, injection administration, Toradol. So we're going to draw some blood from this person. We're going to give them an injection with Toradol. And we're also going to do a screening pelvic exam. Why not? I tried to make this medically reasonable. It most likely isn't. But so we've got a lot going on with this visit. And all of those different elements, again, they're all have their own code. To meet the code requirements, you're going to include that on the claim. And what we have listed then are the charges for those services. All of those charges that are in italics end up being rolled into the CG modifier line. And so that gets you to $320. So $200 for the original E&M plus $120 for these additional services. Note the screening pelvic exam, that $50 charge does not get rolled in because it's one of the preventative services for which there's no copay obligation for the beneficiary. Thus, I can't roll that charge up because why? I use the CG modifier line to calculate the beneficiary's coinsurance, 20% of charges. I want to draw your attention to line number 2, where I have an office outpatient E&M add-on code, the brand new reimbursable G2211. In fact, 2 weeks ago today, we did a lengthy webinar on billing for G2211. Had a lot of questions from rural health clinics regarding what's the impact of this new and complexity add-on code for RHCs. If you're not familiar with G2211, it is a new reimbursement this year on the Medicare physician fee schedule to reimburse for office and outpatient E&M services, a very limited range of codes. You include this add-on code, which is intended to reimburse for the longitudinal care of a patient. So a primary care physician that cares for a patient over a number of years, or a specialist that's managing a condition over a period of time, those are referred to as longitudinal relationships. There's now an opportunity to bill for that on the physician fee schedule. Reimbursement is about $17 additional to the E&M code. So it's always an add-on to an office outpatient established E&M code, new or established patient E&M code. So do you include that on the RHC claim? It's not going to change your air. It's not going to add your reimbursement coming from Medicare. What the inclusion of that code on your claim will do is impact beneficiary coinsurance, because it's a $20 charge when you include the add-on. That's going to increase that number wrapped into the CG modifier line, and thus you're going to end up with the higher paid beneficiary copay. So the Medicare supplemental plan ends up paying you more if there's a supplemental plan that beneficiary has available to them, or their pension benefit, or whatever it may be, or in those cases that patients have to pay for that expense out of pocket, it's going to increase their out-of-pocket costs. So in this example, that's how you get to that CG modifier line with a charge of $320. Now, again, remember, this patient also received psychotherapy services, which is a separate behavioral health service that will also carry a separate error, and so you'll have the CG modifier listed there, okay? But then we had, again, patient gets sick, practitioner goes to their home, so we have a home visit for an established patient. In that instance, I'm going to list the CPT code, the appropriate CPT code. There, I put the 25 modifier. And that's going to indicate to the payer, to the MAC, that's also a separately payable line. So in this one day, this beneficiary had 3 RHC visits, or would qualify for payment of 3 AIR. So if the AIR is, as it is today, $139, we'll say this is a non-grandfathered RHC. Their payment from Medicare would be $333.60, which is simply 3 times the AIR multiplied by 80%. The copay then for this visit would be $124. And how do we get to that? It's add up the modifier lines, the CG modifier lines. So that's 320 the first line. Their charge for the psychotherapy was $150. The charge for the home visit was $150. You add that amount together, multiply it by 20%, that gives you the copay amount. I hope you don't have many days like this in your RHC, but that illustrates to you how the dollars roll into the air, but also how that impacts beneficiary coinsurance, but then also how you list on the claim those separate services. Now, if we really got creative and this person also received an IPPE on the same day, it'd be another line. That would list the 59 modifier in that circumstance. And again, that'd be another payable error. I don't know if we could ever really make that all medically necessary, but at least for illustrative purposes, that's how that would end up being billed. Revenue codes. Very briefly, claims must include the revenue code. The most frequent revenue code listed is 0521, which is a service provided in an RHC. If we go back to our table, you can see the revenue code's 0521, except the last one. Remember, it was a home visit. So that is revenue code 0522. What important to note here also is behavioral health visits are not in the 052X list. They are instead 0900. So that would be the list, the revenue code you will list for those purposes. So that's our RHC visit. Other services that qualify as RHC services are telehealth services. And we're going to talk about two kinds of telehealth: behavioral health services, medical services. Behavioral health services, when furnished via telehealth, thanks to the Consolidated Appropriations Act 2021, those are actually RHC visits because they're going to be reimbursed at the full air. Okay, so it's going to qualify as an RHC visit if that telehealth visit is accomplished using an audio-visual connection, or you can use audio only if the patient cannot or does not want to connect visually. Effective beginning of next year, we're going to have the initial face-to-face requirement kick in. And this has been, it's been suspended by the Consolidated Appropriations Act 2023, but when the telehealth rules change at the beginning of 2025, absent congressional action, to provide a telehealth behavioral health visit that's reimbursed under air, you will need to have had an in-person mental health service furnished 6 months prior to furnishing telehealth services. Of course, if the telehealth services have been initiated prior to January 1st, 2025, the initial visit requirement will not apply. But you're going to have that initial visit at the RHC to receive behavioral health services. Going forward then, the in-person requirement will also require an in-person non-telehealth visit furnished at least every 12 months. Exception eats the rule here because CMS has said that this can be waived so long as the practitioner documents the reason for waiver of the in-person every 12-month requirement. When you bill for these telebehavioral health services, you're going to use revenue code 900, and you're going to list the appropriate HCPCS CPT code and include modifier CG. Again, this is always going to be the primary reason to get that air reimbursed. You're also going to add a modifier 95 when it's an audio-visual connection, and you're going to use modifier FQ if it's audio only. So with that string of modifiers, what you're telling the MAC is this is a telehealth visit. It was performed. It qualifies for air. That's the CG modifier. It was one performed via telehealth, either audio-visual connection, modifier 95, or audio only, that's FQ. Switching gears, let's talk about telehealth for medical services. And here we live in the shadow of the public health emergency still, because these will continue to be covered for an RHC through the end of this year, again, under the Consolidated Appropriations Act 2023. Thereafter, this all goes away, absent congressional action. The service you provide, that medical telehealth service, must be a service that is listed on the CMS approved list of telehealth services. You see there the link to that listing of about 300 CPT codes. Note that that list includes telephone only codes, 99441. That is at least 5 minutes of a telephone E&M service that is not attached to a prior or subsequent visit. So if you provided that service, you have the opportunity to bill for medical services. You're going to bill for this using code G2025. You're not going to use the CPT code for the service you furnished via telehealth. So you're not going to put CPT 99441 on the claim. It won't appear. Instead, that telehealth service is a medical telehealth service, regardless of the nature of the service, so long as it's one of the listed telehealth services, is all going to get billed at on G2025. You're going to list revenue code 0521 for that. And in 2024, this service is reimbursing at $95.29, not the error. Instead, it's a national standardized amount for medical telehealth services is $95.29. So that service, again, the example there is if you are providing services that would meet the definition of 99441, which on the fee schedule is reimbursed at like 20 bucks, it's going to be reimbursed for an RHC at about $95. So this, again, opportunity continues to exist through the end of this year. Please, please remember this hard distinction between telebehavioral health services furnished by an RHC and medical services furnished via telehealth. Because this is always going to continue, this being behavioral health, this is continue to be an error reimbursement forever and ever. You're going to add the in-person requirement, but it's going forward, it's a covered RHC service. Versus medical telehealth services, that benefit's going to go away. And no longer will an RHC be able to bill for telehealth services, medical services. The originating site fee, just to close up the loop here, if you can bill, the RHC can bill the originating site fee when a patient is physically present at the RHC facility to receive telehealth services from a distant site provider. Say the patient comes to your facility, the distance site provider, the specialist, the rheumatologist, the oncologist, whomever it may be, provides a telehealth service while the patient's sitting there in your RHC. You bill the originating site fee using G3014 with revenue code 078X. The reimbursement for 2024 is just shy of $30. It goes up every year based on inflation. Appreciate that that distance site provider is going to separately bill for their professional services using place of service 2, being telehealth services, patient not physically present in the home. The RHC is not required to obtain the provider's notes to bill for G3014. What is to be documented is the fact that you've had the patient physically present and presented them for purposes of receiving services from the distant provider. Their service is separate and apart from the service furnished by the RHC. The third type of RHC service, so we talked about RHC visits, we've talked about telehealth. This is number 3, care management services furnished by RHCs. This is billed under G0511. This is billed for when one of the following services that's listed on the slide are furnished by qualified RHC staff under the general supervision of an RHC practitioner in compliance with the applicable billing codes for that service. The reimbursement in 2024 for any of these care management services is $71.71. Those that are marked with an asterisk, beginning with community health integration, going through remote therapeutic monitoring, those are all new in 2024. So this opportunity has expanded significantly for RHCs that now they're able to be reimbursed for providing remote monitoring services, as well as principal illness navigation and community health integration, as well as those core services that have previously been provided. Also, the beauty here is this is not practitioner time. The practitioner is providing general supervision for appropriately qualified staff. For most of these services, that is going to be clinical staff. But note, when we get deeper into the rules for community health integration and principal illness navigation, those are services typically provided by an individual who would be a community health worker. and that person is not necessarily clinically trained. So again, that's a broader opportunity for our RHCs. General supervision does not require physical presence at the time that the service is being provided, nor does it require a co-signature on every note prepared by that RHC staff in furnishing these services. There is one exception, a different care management code, which is G0512, which is the psychiatric collaborative care model. The reimbursement there is significantly higher at about $145, but it is a very distinct service. Won't go into detail here on the requirements for billing the psychiatric collaborative care model, but that reimbursement is available. Also new in 2024 is CMS telling us very clearly in the final rule that a RHC may bill G051 multiple times in a calendar month, provided all requirements are met and resource costs are not counted more than once. Back in December 2019, CMS published FAQs that explicitly said 1 unit of G0511 per month, that's it. So this is a change and really creates a significant opportunity for care management services in RHCs. Now we've got some open questions, okay? We don't know, for example, if you are providing chronic care management services before this final rule was published, you build 1 unit of G051, regardless if you provided 20 minutes of services, 40 minutes of services, 60 minutes of services, which is different than the fee schedule because there's separate codes you bill for those additional 20-minute increments. Now the question is, hey, if I do bill, if I have 40 minutes of care management services, can I build 2 units of G0511? CMS just hasn't directly addressed that question yet. Hopefully they will soon. And then there's the whole issue of remote monitoring services, because that is a multi-component service. As you see there, there are at least 4 codes associated with remote patient monitoring. Are we going to bill G0511 for each separate component? Not exactly explicitly addressed and answered by CMS. I think the answer is yes, based on my best reading of the guidance, but again, not directly addressed this issue here. Also appreciate that both G0511 and G0512 are payable if billed on the same day as an RHC visit. So these don't roll into the air. They're going to be standing on their own. You're going to have a line that says G0511, you're charged for it, not going to roll in to the air, and it will be reimbursed to that 7171 rate.
All right, now we move to the 4th opportunity, which is community technology-based services. And a service that can be billed under the G0071 includes virtual non-face-to-face communication between the patient and the RHC practitioner. This must be at least for 5 minutes to qualify. However, the patient has had to have had a face-to-face visit within the last year. Of course, they have to consent to receive this type of service. In addition, the medical discussion or remote evaluation is for a condition not related to services provided within the previous days, and then cannot lead into a visit within the next 24 hours or soonest available appointment. So there's a caveat of that timing of when that G0071 can be billed. So you have to be watching for those parameters of prior to and after to see if it's going to be separately billable. The 5th component includes our vaccinations for influenza and pneumococcal. And this includes the administration of as well as the vaccine. These charges are reported on the cost report. For provider-based RHCs, they get placed on your worksheet M4. For independent RHCs, they're placed on the B1 portion of that. You do not bill these or report them on your UB04. And again, these are situations in which your co-insurance copay would be waived for those particular vaccinations.
No rolling those charges into the CG line.
So here we're going to talk about some non-RHC services, okay? It's not that you can't provide them. And as Martie included on her example, the charges get placed on that bill, but they're non-RHC services you can provide. It's confusing. Anyway, for example, these are the lab tests that are done, or for independent RHCs, these are things for example, in the lab, for an independent RHC, you may perform the lab. That goes on your Part B or 1500. For your provider-based, that bill would go on the hospital's UB04. However, the course of venopuncture becomes part of that error rate. The same sort of method applies for diagnostic tests that are done in the RHC, such as X-rays, EKGs, and so forth. The professional, as mentioned earlier, professional services that an RHC practitioner provides in that hospital or outpatient setting does not get included on that RHC bill or included in the error rate. That again gets separated to be on that 1500. Note, if you're a critical access hospital and have elected to bill method 2, that professional component doesn't hit the 1500, but you can include it on the hospital's UB04 bill for that professional component. All the costs associated with non-RHC services, so your space, your overhead, your equipment, must be removed from your cost report. In addition, if you have some extra space in your RHC, which you have visiting providers coming in and using, that lease space time also needs to be, and they bill for it separately, that also needs to be removed out of that cost report. So there's considerations that you need to be monitoring specifically for your cost report, depending on how you're going to get reimbursed for that.
Yeah, I mean, Traci, this is just hard to get your head around, I think,
Yeah.
but it's as if you got the RHC doing the RHC services. And then at the same place, you've got a physician practice, what would be a physician practice providing non-RHC services. And it's billing those on the fee schedule, just like any physician practice would. It's just, there's this little unit of services that qualify as RHC services that are billed in the ways we've been talking about. But once you get out of those services, and you get these different, the providing services in the hospital or the technical component of tests, all that's going to be treated on the fee schedule. And remember, there's no rule you have to provide certain services in the RHC. And that's a whole nother art form.
Yeah.
It's figuring out when it should be provided in the hospital and when it should be provided in the RHC. And there's no rules that you can't, you can separate visits. You can do preventative services on a different day than you do E&M services. So there's no mandatory putting it all in one visit. It's, again, you have to just manage it to make sure you're getting appropriate reimbursement and also not making your patients mad because they don't want to come see you every day.
Right, it's that dance of, convenience, the right thing to do, right.
Yeah, exactly. Very quickly, let's just hit on MIPS because why not? RHC services are not ever subject to MIPS adjustments because they just are, they're Part A reimbursed, they're not Part B, they're not subject to MIPS. However, when a RHC practitioner furnishes a non-RHC service, we've just been talking about, because again, it's just the normal physician practice next door and co-located with a RHC, they are going to be subject to MIPS for those services. The exception, of course, is if you meet the low volume threshold. You see the requirements for that here on the screen. If you've got services that are reimbursed under CAW method 2, again, services furnished in the hospital that are billed by the CAW and receive 115% of the Medicare physician fee schedule, they are going to be included in the calculations for low volume thresholds, and the MIPS adjustment will actually apply to what the CAW receives in its reimbursement. So that's made for some interesting issues going forward with that. So there's our whirlwind through the wonderful world of RHCs. We are our next Regulatory Roundup webinar on March 6th. You are in for a treat. Barry Mathis is going to talk about cybersecurity and how there have been some significant changes in that landscape and regulatory sense. Please, 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 if you all have questions after this presentation, stick around, complete that survey. 2 questions, 3 questions, but there's a chance for you to add questions in and send us those questions. We do respond by email. Sometimes we're a little slow. I still have about 10 questions to go from the G2211 webinar. I apologize if one of those people that have got a response yet. But we will get to those questions. We want to be able to help and make sure you've received all the information you need. So there you go, Traci. Anything on the way out the door?
Nope, thank you. I hope you got it. You're gonna hit the ground running.
Awesome. And again, if you one other thing, if you got other topics that are impact rural health you'd like to have us address, drop that note as well. We want to make sure we're providing relevant content for you all. So thanks so much. Trevor, back to you.
Thanks to our presenters, Martie and Traci. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, www.pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.